Bismillah ar-Rahman ar-Rahim. Welcome to ICON 2022, the cardiology session. This session is about the COVID and heart-related issues. Our first speaker is Dr. Rizwan Ali Mohammad. Rizwan is an electrophysiologist in Albany, New York. He's an assistant professor at Albany Medical Center and a very renowned and established electrophysiologist. He has published numerous articles in cardiac peer-reviewed journals and is very well known for his ablation procedures in AFib and ventricular tachycardia. We are glad to have him with us this morning. It's in fact tonight. It must be 9 or 11 p.m. at in New York. So let's listen to him as the first speaker. Shuru kare.
Topic of the talk is acute coronary syndrome and myocarditis in COVID-19 patients. The acute coronary syndrome and myocarditis is very common. The myocarditis is
Albany Medical Center and an assistant professor there. I thank Indus Hospital for this invitation in this important conference in bringing healthcare providers forward in sharing their challenges and the dilemmas that faced COVID-19 pandemic. Today we will talk about the challenges we faced during the pandemic, especially in the cardiovascular care and electrophysiology. COVID-19 was one of the leading causes of hospitalizations, morbidity, and mortality around the world. It resulted in a lot of disruption throughout the healthcare world. Systems had to evolve, protocols had constantly changed to keep up with the waves, and COVID uncovered weaknesses in every system, challenging its both human and material resources. Basically, we all evolved out of this as a more efficient force and learned how to adapt. So far, as of January 1st, 2022, a total of 289 million cases have been reported, which claimed 5.4 million deaths. Pakistan reported around 1.3 million infections. 28,941 deaths were reported. If you compare Pakistan to the rest of the world in this graph, we see parallel trends and directionalities in both cases and deaths between the two. However, initially, if you look at Pakistan trended slowly in the first wave, but then it all caught up with the rest of the world. I think due to the absence of comprehensive contact tracing and database inherently projected lower numbers than reality. Absence of testing or access to healthcare or even acceptance of the ravages of the virus had an impact on how each country faced and responded to their first wave. If you look at testing, access to healthcare is a fundamental need for any population. Testing means more understanding of a true prevalence, resulting in better planning and response to pandemic. And we have to understand the background of COVID-19 to understand what difficulties a electrophysiology community faced. UAE was an outlier. It had tremendous testing capacity, and which resulted in 99% vaccination rates. Countries like Portugal and United States had respectable numbers, but clearly Pakistan lacked in any testing, uncovering the lack of human and material resources. And we learned. If you look at all these countries and their vaccination rates, everybody was struggling. However, certain healthcare systems were successful. And if you look at Pakistan, the share of people fully vaccinated are 31%. This is as of January 1, 2022. Share of people who partially vaccinated were around 11%, a total of 43%. So we are lagging. We still have to work on this, and we are behind in this endeavor. The United States has 4% of world population, but as of July 16th, approximately 26% of its COVID-19 cases and 24% of COVID-19 deaths throughout the world have been reported by the United States. I want to talk about comparing COVID-19 deaths to non-communicable diseases. It was still the leading cause of deaths during the pandemic. In 2020, WHO assessed 41 million deaths worldwide from non-communicable diseases like cardiovascular disease, cancer, diabetes, respiratory diseases, etc. 44% of these deaths were from cardiovascular disease. Each year, more than 15 million people die from non-communicable disease between the age of 30 and 69 years. These premature deaths, most of them happen in low and middle income countries. And again, it becomes even more important for us in Pakistan and other low and middle income countries to realize that we cannot ignore non-communicable diseases. Well, what were the consequences of COVID-19 on healthcare? Overall, first of all, there was this sudden increase in demand for specialized care. We needed more ICU beds. Normal floors were converted to ICU beds. Nursing staff that had never covered ICU were forced to do that. There was a decline in office visits, resulted in delayed discoveries of non-communicable diseases in patients. There was higher prevalence of uncontrolled chronic illnesses that was observed in lower socioeconomic population. Again, there was substantial racial and ethnic disparities noted during COVID pandemic and how healthcare was provided to these vulnerable populations. The healthcare workers were impacted by COVID-19 as well. It led to burnout and discontinuity of healthcare workers. Even in developed countries, if you look at it, there was scarcity of resources, and not everybody received the optimal care that it should. So COVID-19 certainly presented substantial challenges to the electrophysiology community. Due to the undetermined course, regional variabilities of the pandemic, there was no standardized protocol, and it all differed based on mechanism of care, the burden of illness in the community, and the time of the peak infection rates. We used steroids to hydroxychloroquine to IL-6 inhibitors to antivirals. All these things made significant effects on how patients experienced arrhythmias around the world. There were challenges that were accelerated, the realization of modernization of patient care and how we change protocols, both inpatient and outpatient care, to maximize our reach to the patients. Every EP program worldwide, if you look at, and there were surveys, had to change and make changes accordingly. But why would COVID patients get arrhythmias? Well, both pro-inflammatory state and oxidative state has been repeatedly implicated in the pathogenesis of severe COVID-19 infection, with several treatments that are proposed to mitigate these inflammatory cascades, including hydroxychloroquine, corticosteroids, IL-6 receptor inhibition. Hypoxia has been the most common presentation, and therefore pulseless electrical activity was the most common arrhythmia during a cardiac arrest. Myocardial injuries due to viral invasion via angiotensin converting enzyme 2 have also been implicated in the pathogenesis of COVID-19 associated myocardial injury. And most common arrhythmia incited by this cascade was atrial fibrillation. What were the consequences of COVID-19 on patients? Well, CDC on June 30th, 2020, an estimated 41% of US adults reported having delayed or avoided medical care during the pandemic. Even those who wanted to access care were not able to get primary care physicians, and they were directed to emergency or urgent care, and they avoided those as well. Elective procedures were suspended. That resulted in more morbidity, like if a patient with heart failure symptoms, CRT therapies, etc. This was in the beginning phase of the pandemic, and then we slowly started to triage these patients and started procedures to help the patients. Well, this was an article from New York Times in April 2020 that talk about where have all the heart attacks gone. Yale Hospital reported a substantial decline in heart attack and stroke patients. Their inpatient cardiology consultations went down. They even noticed lower cardiac presentations, lower rate of cardiac presentations in the ED. And patients were presenting later in their heart attacks when there was little salvageable. This was very concerning for the healthcare workers and providers in the emergency room as well as the patient side. In Karachi, Al-Khan University also reported 55% reduction in cardiology admissions in AKU from 2019 to 2020. So they also, in Pakistan, they saw a decline in cardiac patients. In United States, one of the big healthcare system reported the highest ever number of cardiac arrests in the field, 45% more than previous month. This is around the time of March, April 2020. More cardiac arrest, 45% more cardiac arrests were seen. Nationally, the ED visits were down in April 2020 when it comes to cardiac and non-communicable diseases. Hospitals were seen as infectious reservoirs. There was an overarching theme within patients when they were surveyed that there was fear, and patients outweighed cons of COVID infection over normal health concerns, and therefore they avoided and presented late. What was the impact on electrophysiologists? There was certainly a dramatic drop in EP procedures. This is from a worldwide survey, around 20 to 95% decline. In outpatient settings, people came out of their cocoon. They changed the protocols on how we treated patients and what we did with the outpatient procedures. We started discharging patients, even the ones that we never thought we would, like atrial fibrillation ablation or VT ablation. Patients with new CRT devices that we used to keep them overnight to make sure everything's fine. We discharged those patients. There was a decline in drug loading admissions. What I mean by that is it's fairly prevalent to have dofetilide and Ticasone loading admissions. Hospitals closed down on those admissions, so we changed our protocol. Amiodarone was used more. We changed our protocols in outpatient settings where we would start patients on sotalol and would see them every morning for 3 days in a row, and check their EKGs. So we all came out of our cocoons, and this pandemic did accelerate and improved our processes to adapt even other things like remote care. Physicians who already had a established telehealth and remote monitoring, they were able to continue care without further hurdles. So a lot of changes happened in electrophysiology practice, where there was a trend towards remote monitoring. Well, these were the priorities in the EP lab after the first 40 to 50 days of the pandemic. The urgent and emergent cases, as you can imagine, were VT ablation for refractory VTs, highly symptomatic SVT ablation, WPW patients with pre-excited AFib, lead revisions, generator changes for pacemaker-dependent patients, secondary prevention ICDs, lead extractions for infections, CRT for refractory heart failures. These were the patients were deemed as urgent, emergent, and we started doing those procedures. But I'll tell you, all of these patients were discharged on the same day. TEE was discouraged during the pandemic, and we started substituting it with cardiac CT to rule out any thrombus. Cardioversion was performed sometimes in outpatients as well after a negative test, but cardioversions went up substantially during the pandemic. So if you look at EP labs, there was a lot of justification of creating new EP rebooting teams, and teams were made to prioritize who and who cannot get procedures. Well, it was all regional, depending on what the disease burden was. All patients were tested 12 to 72 hours prior to the procedure. Everybody was screened for symptoms and high-risk exposures. Same-day discharges were encouraged. And we obtained additional consent from patients, first of all, to explain them why we're doing this procedure in an urgent or emergent fashion, and their risk of COVID-19 infection in that encounter, so that we understand that we're all on the same page. What did we do with the priorities in the EP practice other than inpatient? There was reduction in device reps in the clinical areas to reduce exposure. And only patients that came into the clinic were the ones who had clinically actionable suspected arrhythmias. They needed reprogramming, or there was evaluation of potential arrhythmic symptoms or alerts in patients which were not remotely followed. So again, it highlighted the need for remote monitoring. And seeing this, patients who actually did not want remote monitoring asked for it and were expecting from us that we would take care of them remotely. This is a study from Philadelphia. It was published in Heart Rhythm Journal in 2020. They looked at 700 COVID-19 patients, and it was a 9-week follow-up. And they found 9 cardiac arrests in those patients, 25 atrial fibrillation events, 9 clinically significant Brady arrhythmias, and around 10 unsustained VTs. They concluded that COVID-19 was associated with a high incidence of cardiac arrhythmias. They said severe acute infection may cause injury to cardiac myocyte and increase the arrhythmia risk. And they said cardiac arrest and arrhythmias were likely the consequence of the severe illness, the systemic illness, and not solely the direct effect of COVID-19 infection. All the cardiac arrest patients were found in the ICU, and they did not have cardiac arrest prior to the admission to the ICU. And all the patients who had developed arrhythmias had no prior arrhythmia history. These are prevalence of other arrhythmias that I mentioned in the previous slide. There was acute in-hospital mortality rate was around 20%. Cardiac arrest rate was 11%. This is Philadelphia group. New York group showed 13%. And they say that this was high because of the prevalence of use of hydroxychloroquine and azithromycin in these patients, resulting in QT prolongation and independently increasing the risk of cardiac arrest. Importantly and interestingly, all cardiac arrest patients in this study, the Philadelphia study, had non-shockable rhythms such as PE arrest or asystole. Only one had torsade de pointes, and folks in Philadelphia did not see that burden of VTVF that was reported by the early experiences in Wuhan. So if you look at the worldwide survey, the data was collected from 4,500 patients across 4 continents, 12 countries, and they saw 827 of them had arrhythmia. They noted that protocols varied significantly across the globe likely because of what was available to them, the burden of illness, and the timings of their infection rates. The mortality rate average global was 48% from the admitted patients. Some places had higher numbers. For example, the Lombardy region of Italy, in the first 40 days, there was a 58% rise in out-of-hospital cardiac arrests. So every place was slightly different from each other. United States, being not so populated, as I mentioned before, was 25% of all COVID cases. In those patients, worldwide survey, 81, these patients actually had overlapping arrhythmias, some of them. 81% had atrial arrhythmias, 20% ventricular arrhythmias, 22% had bradyarrhythmias. There was lower incidence of atrial fibrillation in Asian patients. More hydroxychloroquine was used in the Western Hemisphere. And if you note here, 43% of those who developed arrhythmias were sick enough and had were mechanically ventilated, and 51% made it to hospital discharge. And when they surveyed the electrophysiologists, almost everybody said they had a lower incident drop in their EP procedures. Well, why did Asians have lower atrial fibrillation? It depends on the mechanism of care, the population characteristics. It dictates the incidence of arrhythmia in a population. There was lower history of hypertension, diabetes, lower BMI. There was more use of antivirals in Asia, but there was more bradyarrhythmias or bradyarrhythmias in the Asian population. I have to note here that 73% of the patients who died had their telemetry turned off. So we don't know every lost rhythm on these dying patients. Most of them were anticoagulated, and we've seen this worldwide because of atrial arrhythmias. And because of the scarcity of resources, not everyone got echoes and EKGs, even in United States. So you could tell how much havoc this pandemic had created. Well, there were atypical presentations of myocarditis and AV node blocks. We've seen malignant ventricular arrhythmias with COVID-19 patients, and doctors were puzzled with higher incidences of cardiac arrest in population with hydroxychloroquine use. So caution was shared. Particularly, atrial fibrillation was noted to be an independent predictor for in-hospital mortality. This is a New York study. 9,500 patients were reviewed. 17% had experienced atrial fibrillation. 65% of those AFib patients were new onset of atrial fibrillation. There was higher risk of mortality amongst atrial fibrillation patients. And atrial fibrillation patients also had higher rates of mechanical ventilation. So it tells us that it is a marker of more severe illness. And that was the challenge that they faced. It was suggested that COVID caused AFib through altering the atrial cellular electrophysiology, also disrupting the angiotensin II cascade as well. I want to show you this a remote transmission from a patient who had a Boston Scientific device. It's a defibrillator, and it's showing this heart logic index, which is a culmination of multiple clinical parameters. When they worsen, it crosses the threshold in the gray zone, and you can see that this patient avoided hospitalizations whenever it peaked. It was intervened by remote care team. Patient was diuresed and was brought back down to below the threshold. Interestingly, every time this patient had a congestive heart failure or crossed the heart logic thresholds, the patient experienced atrial fibrillation. So certainly interesting to look at and trend. This is an example of a previously ablated atrial fibrillation patient who had a sudden onset. This is December 2021, so I'm sharing this rather very recent one. And this patient was then, we called this patient, changed his medications, and was remotely managed. I'll tell you, in our inpatient and outpatient settings, more rate control strategies were adopted during this pandemic than rhythm control, which we obviously like to do. If you look at patients who already were on remote monitoring, there was a distinct advantage. Clinicians could rapidly and efficiently identify and triage patients with significant arrhythmias or device malfunctions, and then reassure the remaining patients to avoid medical environments. The present state is a little cumbersome. All data is evaluated with equal urgency, and attention is required from physicians or allied professions. Future, we would like the data to be sorted out by urgency, utilizing AI, artificial intelligence, and clinical pathways to guide the staff. All urgent transmissions should go to MD, AP, or APs. Artifacts should be removed from any reviews, and then the semi-urgent and electives can go for the next business day to decrease the workload. So this is a very good article that Sana Al-Khatib from Dartmouth wrote, and it was published in Heart Rhythm Society Journal in 2020. That certainly in this pandemic, the tools of these digital health are facilitating a paradigm shift to a more patient-centric healthcare delivery system. Our current system, and look at worldwide, that we are stuck in 20th century closed loop delivery model. In old system, clinicians place an order for diagnostic or therapeutic interventions, which are then performed within the traditional boundaries of our clinical office. But we need to change that, and we need to build infrastructure to process and triage and incorporate these digital health data which are generated outside the medical boundaries or medical buildings. So we must transform our established healthcare infrastructures, technologies, workflows to efficiently take care of this. And then, depending on the regional resources, of course, things may or may not apply to one country or the other. We should do research to how we can inform the effective development and implementation of these tools, and identify what works and does not work in a given environment. With that, I thank you for your attention.
Thank you, IB Online. Thank you, Dr. Rizwan Ali Mohammad, for interesting talk. Is he online, Rizwan?
Assalamu alaikum. I am.
Waisla. Yeah, okay. That's a very interesting review of cardiac-related health issues during the COVID pandemic. I have a few questions. One is, COVID has taught us to take care of patients in a different way than we were used to before. So you certainly mentioned that there has been a decline in cardiac admissions and cardiac procedures during the COVID pandemic. But did the cardiac mortality go down, or did it go up when we were not taking care of these patients?
Yes.
Should I continue, or?
Yes.
And the second question that I have is, what's the impact of this current COVID wave that you have in the United States? And my last question is that your strategy in AFib during this COVID patients, for these COVID patients who were sick and in ICU, was basically rate control and anticoagulation, or you did try to restore them back into the sinus rhythm?
All right. So I'll take one question at a time, Dr. Takim. So when it comes to mortality, as I mentioned, throughout the worldwide survey, there was more out of hospital mortality noted as cardiac arrest. We did start seeing a trend although there is no reason or data present that how much more cardiac arrest we had inpatient. But we know that people were presenting late in their heart attacks, and they were sicker, and we saw more unsalvageable heart attacks, at least in the first wave in United States. So to answer your question, that I think the mortality did went up, but we don't have an account of all of those. There were a lot of mortalities that were unaccounted for in the pandemic. So maybe in next few years we'll go through this through Social Security database, and then we'll give you the answer. The second question is was about the rate control. What was the second question?
The question was the impact that you have of this current
Yeah.
COVID wave in the United States.
Yeah. So what we're seeing here now is it's actually it's affecting our material and human resources much more than the first wave or the second wave. The Omicron is spreading much more rapidly. I would tell you about 2 weeks ago we had 500 nurses in our hospital that were infected, and pretty much everything shut down in the hospital. We are still continuing our elective procedures, but I'll tell you that any day now we can shut down. So the resources are being challenged actually much more because of the strict criteria in the hospitals for quarantining the nurses and the physicians. And I hope that we go through this in the next few months. The third question that you had, Dr. Dakam, is about the rate control and rhythm control. I'll tell you that once you're in the hospital, we'll try to do a rhythm control. But if you're not, most of the patients who were presenting with rapid AFib in emergency rooms were being discharged after a few hours of trials of rate control medications here. And we were not admitting those patients if we could control their rates in the emergency room and then send them out. So the rhythm control did take a little sidetracked during this COVID pandemic.
I have a question.
Yes, Imran.
I have, Dr. Rizwan, thank you very much. It was a very comprehensive talk on the arrhythmias. We have been dealing with this very, very fast atrial fibrillation with low blood pressures. And in Pakistan, we have got very limited number of drugs available. We can use amiodarone or digoxin sometimes. I was just curious, what is the role of ivabradine in the control of atrial fibrillation? Can we use it or not?
Ibutylite, you said? Did you say ibutylite?
Ivabradine, rate control.
Yeah, so Imran, we don't use that often here at least in the United States for rapid atrial fibrillation. We if you are in the hospital and if we can use ibutylite, we have used that in a hypotensive patients. Obviously, digoxin is number one option. Then obviously you have think about your cardioversions. Think about, we also use Ticasin in those patients. So we try to use those three options if you're inpatient. If you're outpatient, then all bets are off. We try to do amiodarone most likely because you don't have to deal with the QT, EKG surveillance and all that. But recently we've started doing sotalol loads outpatient, where we start this 8 in the morning and the patient shows up 10 in our clinic, and we get our EKG and we send them home for the next day.
So thank you very much. Thank you.
Thank you, Rizwan. And I would like you to join us for the next two presentations. If there are any other questions, we will forward it to you. Should we go to the next presentation? Next speaker is Dr. Ahmed Noor. He'll be talking about myocarditis and COVID-related pandemic. Thank you.
My topic
Thank you very much, Rizwan, for being
talk
with us.
is acute coronary syndrome and myocarditis in COVID-19 patients. The acute coronary syndrome and myocarditis is very common. The myocarditis is more talked about and less common, but the acute coronary syndrome is fairly common in COVID-19 patients. So today we will be talking about spectrum of cardiac disease in COVID-19 briefly, the basic pathophysiology of the cardiac involvement because of the COVID disease, diagnostic tests for myocardial injury and myocardial ischemia, and also diagnostic test for myocardial stress, the ST elevation MI and non-ST elevation MI, and acute heart failure. So talking about the cardiac involvement, patients can come in cardiac shock, cardiac arrest, complicated by the COVID, or they can be COVID positive and may be coming with acute cardiac issue leading to cardiac shock or cardiac arrest, the ST elevation MI, acute coronary syndrome, non-ST and unstable angina, or they can come with chronic stable angina, and sometimes patients come with acute heart failure and they may be coming with arrhythmias. So this is all the spectrum of the disease that we see in patients with patients with COVID-19. When we see consults in COVID units, we should try to place the patient in one of the three categories. So patients can be having COVID-19 and along with that they may be having cardiac event like heart failure, ACS, arrhythmia, venous thromboembolism, and they may be in cardiac shock or cardiac arrest. So all of these need a quick diagnosis and management and should not be overlooked due to the presence of COVID-19. So primarily cardiac disease should be sought in these patients. The other group is the patients with COVID-19 but having clinical picture suspicious of cardiac involvement. And the cardiac involvement is a differential diagnosis, but it's not a specifically primary diagnosis of the cardiac. So they have COVID-19, they may have infiltrates in the lungs, and one can think of differential diagnosis of acute heart failure, and we should then look for heart failure. Primarily, they may be having just the COVID infection. Similarly, patients with COVID-19 can be having chest pain, dyspnea, and shock, even in the absence of cardiac injury. So we should try to place these patients in three categories. One, having primarily cardiac issue with COVID. One, having primarily COVID and no cardiac event, but having symptoms. And those who have both as a presenting illness. So as we know that the pathophysiology of the COVID-19 start with the ACE2 being expressed on the surface of the alveoli, and that leads to the binding of the virus to the alveolar membranes. In this alveolar membrane expression is also leading to the complications in the lungs, but the ACE2 is also involved in the manifestation of the cardiac complications like microvascular dysfunction, endothelial dysfunction, plaque rupture and instability, heart failure, and arrhythmias. So when we talk about the myocardial involvement, the cardiac injury and the myocardial ischemia can be measured and quantified by the cardiac troponin. So we always take history, we do examination, we look at the ECG, and then we look at the cardiac troponin T or I, whichever is available, to look at the myocardial injury or the cardiac injury because of the COVID-19 or is a primary presentation of the patient. So when we look at the troponins, as we know that the CPK and CKMB are now abundant as a cardiac injury markers, and we rely on cardiac troponins. Usually from the day of illness, it usually takes, it's around the second week or the third week that patient will have more rise in the troponins. In the first week, they have minimal rise of troponin. In COVID disease, the mild elevation in cardiac troponin can be seen. And similarly, a mild increase in the NT-proBNP and BNP can be seen in general. And this may be the result of pre-existing cardiac illness or the acute injury or the stress related to COVID-19. While in the absence of typical angina, chest pain, or ischemic ECG changes, these patients usually do not require any further test or workup if they don't have any ECG changes suggestive of myocardial involvement. While marked elevation in cardiac troponin, which is more than 5 times, that indicates the presence of shock as a part of COVID-19. It may be in severe respiratory illness, systemic hypoxia, myocarditis, all of them, or it can be type 1 myocardial injury, which is triggered by COVID-19. So in short, if we look at the cardiac troponin will increase usually in the second week, number one. Number two, if it is minimally raised up to 2 times, and they have mild symptoms, the mildly elevated troponin should be disregarded. While troponin, which is more than 5 times, is usually because of a type 1 MI, myocarditis, or Takotsubo, or cardiogenic shock, and that should be further pursued and treated. While minimally raised troponin is seen in patients with no clear STT changes, ST elevation is also common in patients with COVID-19, and we see this. So the COVID-19 ST elevation MI should be treated like the ST elevation MI in all other patients. So initially, when the pandemic started, there was a lot of shift of treatment protocol from no intervention to giving them just thrombolytics, and then the guidelines, the guidance actually came that these patients should be treated with primary angioplasty if possible. So in patients who are less than 12 hours duration of chest pain, and there is persistent ST elevation, the first thing is reperfusion therapy. So we should try to reperfuse them either with primary angioplasty or with the thrombolytic. So the testing for COVID-19 should be done as soon as possible. There should be a institution-based revascularization protocol for fibrinolysis or primary PCI, and we should avoid stage procedure. So immediate complete revascularization as much as it can be done, or The other option is to just leave the non-culprit vessel for later revascularization and evaluation. But if one feels that apart from the target lesion, they need to fix the other lesion, which is not the target vessel, that should be fixed in the same setting of primary PCI. So the main principles of ST elevation my management in COVID-19 is that all of the patients should be treated as though they are COVID-19 positive. The maximum delay for the STEMI diagnosis to the reperfusion should be less than 120 minutes. And the primary PCI remains the reperfusion therapy of choice. Primary PCI may be delayed during the pandemic due to delays in the delivery of care and the implementation of the protective measures. If the target time cannot be met and it is not contraindicated, people should give thrombolytic rather than waiting for the primary angioplasty. And the last thing is that the COVID-19 test should be done as soon as possible. The non-culprit vessel should either be treated in the primary setup during the primary angioplasty if we see that lesion is unstable or very critical, or it should be delayed till that peak of the pandemic subsides, and that lesion is then treated in another session after the patient is discharged. So in short, patients should be referred for primary angioplasty if possible. Otherwise, they should be given thrombolytic like the way we give it to other patients. The pharmacological treatment is almost the same as the patients without COVID-19. So all of these patients do not have any other specific contraindication to dual antiplatelet, regular or low molecular weight heparin, the ACE inhibitor, ARB, statin and diuretic and aldosterone antagonist. Obviously, we have to look at their renal function when we give them ACE inhibitor or ARB. Otherwise, the treatment is the same. The other set of patients are those who come with cardiac shock and sudden cardiac arrest, and they survive with the resuscitation. As we know that the management of cardiac shock and out of hospital cardiac arrest is very much time dependent. So the minutes earlier we intervene, the more patients we can actually save. So the invasive coronary angiogram remains the mainstay of treatment, and it depends on the setup of how quickly we can intervene in these patients. Use of mechanical assist devices should be individualized to these patients. Some of the patients may need prone ventilation, for example, for COVID-19, and obviously then you may not be able to place intra-aortic balloon pump. The patients with the acute coronary syndrome, apart from the cardiac shock and ST elevation MI, are the ones who come with unstable angina or non-ST elevation MI. These patients should be risk stratified into very high risk, the high risk, intermediate risk, and the low risk patients. So the high risk are those who are hemodynamically unstable or in shock. They have recurrent chest pain, life-threatening arrhythmias, mechanical complications of acute MI, acute heart failure, recurrent intermittent ST elevations. So for all of these patients, they are very critically ill patients, and we should follow the STEMI pathway. So we should treat them as soon as possible with cardiac cath and primary intervention. Then the second category is high-risk patients. Among these, the patients will fall are those who have dynamic STT changes or they have recurrent symptoms. And they have established non-STEMI based on the positive troponin. So positive troponin, dynamic STT changes, and recurrent symptoms, their management is medically the same, but the cath should be done in less than 24 hours. And then there are intermediate risk patients, those who have diabetes, renal insufficiency, or LVEF less than 40, and their troponin is negative, so they have unstable angina. They should be, and they also have COVID-19, so they should be preferably in a COVID hospital. And cath preferably should be done in the same admission if it is possible. So then there are low-risk patients who do not fall in these categories. One should try to defer cath till after the peak of the COVID wave is over. And once the patient is non-infective, then we can do cath. So in short, those patients who come with acute coronary syndrome, they should be categorized as very high risk, intermediate risk, and low risk. And then if people are falling into the low risk category, we should try to defer their cath for another admission after their discharge, or they can be risk stratified with the stress test after they become non-infective. By the way, the stress test is also very high risk for spreading of the infection, because when patients stress, they hyperventilate, and the environment can get a lot of people can get infected in that situation. The other category of patients who come with COVID is those who present with acute heart failure. So the acute heart failure may complicate the clinical course of COVID-19, particularly in severe cases of COVID. The underlying mechanism can be acute myocardial injury due to ischemia, infarction, or inflammation, acute respiratory distress syndrome, acute kidney injury and hypervolemia, and stress-induced cardiomyopathy and tachyarrhythmias. So acute myocardial injury, acute myocarditis with direct COVID infection is pretty rare, but it's talked much more than it exists. So these are the patients who come with acute heart failure. Their LV function prior to this is normal. Their LV, the chamber sizes may be normal, and these patients are treated in the usual fashion. Sometimes patients come with the COVID pneumonia and acute heart failure, and their clinical picture is such that it's very difficult to differentiate the two. And in addition, the two conditions may actually coexist. Then you have to make a sense out of every case of what is happening with the patient. So significantly elevated BNP or NT-proBNP also suggest acute heart failure, while a normal NT-proBNP will almost rule out acute heart failure. So just talking about the NT-proBNP, it increases with the LV systolic dysfunction, LV diastolic dysfunction, valvular dysfunction, and RV dysfunction. So all of these conditions and the RV dysfunction can be quite present in these patients with COVID-19 because they also have increase in the RV filling pressures, in the RV stretch, and that leads to a leak of these. So but those who come with acute LV failure, their NT-proBNP level will be markedly elevated, like in more than 10,000 and in that range. In these patients, we should consider transthoracic echo to assess the LV function. And I think Dr. Imran will be talking about indications and how to smartly use the echocardiography for patients of COVID-19. So we should especially look for early detection and treatment of complications, including the need of non-invasive and invasive ventilation, bleeding events, and cardiac arrhythmias. The spectrum of COVID-19, from ischemia to heart failure to acute heart failure and arrhythmias, I think every patient is different. We should try to concentrate on the patient's clinical status of where to actually fix that patient. Is this patient having only COVID-19? Does this patient have cardiac issue and his COVID-19 is he just positive in his disease activity is not that much, so then we can concentrate on him, on his cardiac status only. Or in another situation, are they both exist, he also may be having moderate to severe pneumonia, and along with that he may be having cardiac involvement. The ST elevation is treated like the other patients, but obviously the complications of COVID-19 will dictate of how we can modify the treatment. But the medical treatment almost remains same. The other thing is that, for example, these patients usually do not have a lot of wheezing, so they don't have a lot of bronchospasm, and many of them actually tolerate the beta blockers quite well. So the pharmacological treatment remains almost the same, though we should look for the patients whose creatinine is increasing because of COVID-19, and there are few patients who have that. The last is the patients with acute heart failure. We should try to identify whether they have acute heart failure or not, or they are just sick because of the COVID-19. So if there are any questions.
Thank you. Thank you, Dr. Ahmed Noor, for the interesting talk. I certainly have question, but if there are any other people who have questions can join us. My question is regarding the role of anti-platelet or anticoagulation agent in preventing cardiac event in high-risk patients with coronary artery disease who are just simply COVID positive. They don't have COVID disease; they are just COVID positive. Because we all know that, because of the severe inflammation, you can have a plaque rupture and a cardiac event.
So till now, there are no guidelines for COVID-19 and ischemic heart disease. There are only guidances. The American Heart Association guidance review was little older, and then in I think end of November or early December, there was a European guidance paper came, and they do not talk specifically about anti-coagulation prophylaxis in these patients to prevent ischemic heart disease or to prevent ischemic events. However, in clinical practice, those who have a D dimer more than 3,000 or 3, depending on the unit, they do receive anticoagulation. Some people give it for 4 weeks, but there is no consensus on for how many weeks we should treat them with anticoagulation.
Any other questions, Imran? Can't hear you.
Hello, can you hear me now?
Yeah, we can hear you now.
Can you hear me now, please?
Yes,
Hello?
go ahead.
Yes, we
Okay. Dr. Pundi has a question. Dr. Pundi has a question from Dr. Rizwan Ali. Dr. Rizwan, were there any patients who were brought in the cath lab for either of the procedures, like uh, intervention, any intervention? Did they contract the COVID infection from the cath lab? Is there any data? There's an issue. I cannot hear.
Rizwan, we can't hear you.
We can't hear you.
So not particularly that I know of data that tells us whether there was patient to doctor or patient to staff transmissions. But anecdotally, we have seen across the region that patients, infected patients, or unknown status of patients with acute MIs have ended up with staff and doctors being infected. So I don't know of data that tells us that what percentage of healthcare workers were infected by acute MIs or cath lab.
Rizwan, did you have a dedicated cath lab for COVID patients in your center?
Yeah. So we did kept a room that was just for COVID patients, and most of the times I know you interventional guys are different from us. In EP, we have more controlled situations than y'all's. But if a patient is intubated, then the team that is inside the room does not leave the room until the case is over, or you cannot leave the room until somewhere around 25 minutes. You have to stay in the room once the patient is intubated because of whatever the aerosol transmission or whatever the theory is. Um, and if you we use the same room for COVID patients throughout the pandemic, and then we would rotate other patients and keep the non-COVID patients in a different part of the cath lab. So there was a dedicated room, not a whole section, but yes. And then the last, and if let's just say if we had no COVID patients that day, and we or there were non-COVID patients and one COVID patient, then we'll keep the last one as COVID, and then we'll use the room in the end, and then close it down for the rest of the night.
Imran, we can't hear you.
Hello, can you hear me? Yeah. So that's what we do over here as well. If there's a COVID patient, we keep it till the end, and then we had the cath lab had to go for a deep cleaning after every patient of the COVID.
Sure.
Thank you. It, do you know of any procedures? How do you deep clean the cath lab specifically after the COVID, or just routine cleaning?
Um, I think there have been multiple ways. I think there are people who have used ultraviolet machines, but what I've seen is basic cleaning with wipe downs, and nothing out of the ordinary, except there were more wipe downs than before.
Thank you, Ahmedur, for this talk. Our next speaker is Imran Iftikhar. He's a consultant cardiologist at Indus Hospital. Imran will be talking about the role of echocardiography in COVID-positive patients with COVID heart-related diseases. Imran, please go ahead.
Iftikhar. I'm an intervention cardiologist at Indus Hospital. The topic that we have selected for this presentation today is regarding the COVID-19 patients. With the advancement of the disease progression of COVID-19 patient, we came across a lot of problems and how to deal with it. And it was because of the limitation that we had with the COVID patients, COVID units. So
the limitation of echocardiography was also highlighted. So this topic, this topic completely pertains to the echocardiography in the COVID-19 patients. What problems do we have, and how do we come about it? ऐसे patients में हमें क्या करना होता है? तो let's start with the first slide. The COVID-19 virus or severe acute respiratory syndrome results in COVID-19 disease that has been declared a pandemic, as you already know. Among patients who underwent transthoracic echo and whose troponin were positive, it was seen that there was six-fold increase for transthoracic abnormalities in these patients, and there was six-fold increase in the in-house mortality of these patients. So most of the patients who had their troponins positive, they had like 5 times increase in the mortality. But with all those that have the wall motion abnormalities in the echoes, so echo was a very important modality that has to be taken care of in every patient who was suspected with troponins high. Compared with patients without myocardial injury, those with myocardial injury had more electrocardiographic abnormalities and they had higher inflammatory markers. So there should probably a low threshold for adding echocardiography or a full transthoracic study or a point of care system for those with the signs of cardiac involvement. So all those patients who come in with COVID-19 and has troponin positive, so we have to have their echocardiography done. That is a very important part. So if you go through this slide, the spectrum of major echocardiographic abnormalities that you will come across the COVID-19 patients are like left ventricular wall motion abnormalities. There was a study that was actually conducted and was reproduced over here in the form of this illustration. So most of them was like LV motion abnormalities. Then there were right ventricular infarction, right ventricular dysfunction, along with pulmonary, the signs of pulmonary embolism. Then there were pericardial infusion in 7.2% of the cases. Diastolic dysfunction was noted in 13.2%, and global LV dysfunction was noted in 18.4%. So altogether, the wall motion abnormalities are either global or segmental made the bulk of the transthoracic abnormalities that you could see in these patients. So what are the targets of echocardiography in these patients who are all COVID positive? आप कोविड के वार्ड के अंदर जाना और आना बड़ा मुश्किल होता है, आपको लोड करना पड़ता है और मशीन्स को लेके आना, और हर जगह मशीन्स अवेलेबल नहीं भी होती. तो we have to have a targeted approach for this. So the main 5 or 6 things that you need to do in a patient with COVID-19 are, I think this is the most important slide for this. One is LV function, either global or regional. It will be associated with myocarditis or stress-induced cardiomyopathy pattern or epicardial or microvascular coronary thrombosis. So LV function is the prime abnormality that is to be seen in these patients. The second is pericardial effusion. And third, especially with the Delta variant coming in lately for like 4 or 5 months back, a hypercoagulable states was a big problem with these patients. So it was associated with deep vein thrombosis. It was associated with pulmonary embolism, with gross right ventricular findings and acute pulmonary hypertension. So these were the findings that we need to see in the patient, especially with the Delta variant as well. Then pulmonary hypertension, and of course the volume status was also very important. So I think this is the basic slide that you need to understand कि हमें करना क्या है patients के अंदर. So LV function देखने के लिए देखिए, there are two major ways in which we have seen. First of all, before going for these things, I would like to tell you कि जैसे point of care system, this focus का point of care ultrasound हम normally emergency patients के अंदर करते हैं. We have got 5 or 6 points. That is a very helpful thing. So इसी तरह point of care echocardiography must be, point of care systems must be developed at every center. आपका अपना जो hospital है, आप उसमें point of care systems बनाएं और आप उसमें देखें कि आपने क्या क्या चीजें देखनी है उसके अंदर. तो when you go through this LV फंक्शन, तो मेन चीज उसके अंदर क्या होगी, पैरास्टर्नल लॉन्ग एक्सिस व्यू, पैरास्टर्नल शॉर्ट एक्सिस व्यू एंड द एपिकल व्यूज। एटलीस्ट ये 3 व्यूज ऐसे होने चाहिए जिसके अंदर आप ये देख सकते हैं। तो ejection fraction is actually an expression of global function. It is a strong predictor of clinical outcomes in almost all cardiac condition, and it is normally determined by eyeballing echocardiographic images. जो eyeballing के जरिए हम लोग देखते हैं echocardiographic images, वो subjective होते हैं, they vary from person to person. मगर अगर senior लोग उसको देख रहे हो तो इंटर रेटेड जो डिफरेंस है, इंटर ऑब्जर्वर वेरिएशन जो है, वो 5% से कम होनी चाहिए। बट इफ द डिफरेंस इज मोर देन 5%, इट मींस कि देयर इज अ प्रॉब्लम समवेयर। तो सबसे कॉमनली जो सबसे ज्यादा यूज की जाती है, दैट इज आई बॉलिंग। सो ये चीज बहुत अच्छी है, हम लोग बहुत जल्दी से देख सकते हैं, जो लोग एक्सपीरियंस होते हैं एकोकार्डियोग्राफी के अंदर जो बहुत काम किया होता है। मगर जो बिगिनर्स होते हैं उनके लिए ये इतना अच्छा नहीं होता, और कोई ऑब्जेक्टिव वे देखना चाहिए साथ साथ। तो ऐसे पेशेंट्स के अंदर देयर इज अनदर वे दैट यू कैन यूज इजीली, क्वाइट इजीली, जिसको हम बोलते that is what we use normally, ठीक है। इट्स अ सिम्पसन्स मेथड। सिम्पसन मेथड के अंदर क्या होता है, हमें आपका इवन 2D और 3D के अंदर हमें 2-3 जगहों पे उसकी रीडिंग्स लेनी होती है और मशीन ऑटो कैलकुलेट करती है। This is a quantitative way of assessing the LV function. We use the volumetric measurements, left ventricular end diastolic volume minus left end systolic volume divided by left ventricular end diastolic. This is the formula on which we use it. So Simpson rule के अंदर it is also known as the rule of discs. This technique requires an apical 4-chamber and 2-chamber views from which the endocardial border is outlined in end diastole and end systole. तो end diastole और end systole के अंदर ये endocardial border, if you see it over here, कि हम पूरे ये endocardial border को इसको trace कर रहे हैं इसका. The first thing is कि we trace the border in end diastole and then we do it in end systole. The ventricle is then mathematically divided along its long axis into series of discs of equal height. ये जो फॉर्मूला है, ये ऑटोमेटिकली नॉर्मली जो मशीन्स होती हैं उनके अंदर डला हुआ होता है। Individual disc volume is calculated as height into disc area. The vertical volume is then represented by the sum of all. तो जितने भी डिस्क हैं उनके जितने वॉल्यूम्स निकालते हैं वो फिर, तो ये आपने देखा कि हम 2 जगहों से इसका कैलकुलेट करते हैं, और ये डिस्क देखें, ये ऑटोमेटिकली इसको डिस्क के जरिए कैलकुलेट करते हैं। एवरी डिस्क इज बीइंग कैलकुलेटेड बाय द मशीन इटसेल्फ. So for a symmetrically contracting ventricle, either the 4 or the 2-chamber view can be used. If there is asymmetry of the ventricle geometry, a single plane view will have reduced accuracy. तो इसलिए ये जो मेथड है हमारा, इसकी थोड़ी सी लिमिटेशन भी है। ये अगर वॉल मोशन एब्नॉर्मलिटीज होगी तो उसके अंदर बहुत अच्छी इसकी एक्यूरेसी नहीं होती। डिफिकल्टी इन ट्रेसिंग द एंडोकार्डियल बॉर्डर, अगर बहुत अच्छी एंडोकार्डियल बॉर्डर आपका ना हो तो उसमें भी प्रॉब्लम आ सकता है। कैलकुलेशन का फोर्स शॉर्टनिंग हो सकती है एलवी कैविटी की ड्यू टू अंडर एस्टिमेशन ऑफ द एलवी वॉल्यूम्स, and it is less reliable in the presence of regional dysfunction. But it is a very good way to actually assess the LV function. So left ventricular systolic volume को देखने के जो 2 तरीके हमने डिस्कस किए हैं, एक तो आईबॉलिंग है, जो कि नॉर्मली आप आईबॉल करके अंदाजा लगाते हैं कि LV फंक्शन कितना है, एंड द अदर इज द सिम्पसन रूल और द रूल ऑफ डिस्क, जो कि हमने कैलकुलेट करके आपको दिखाया। सो दिस गिव्स अ सब्जेक्टिव एविडेंस कि कितना EF है, बट अगर वॉल मोशन एब्नॉर्मलिटीज होंगी तो इट इज डिफिकल्ट टू calculate. 3D, we're not going to discuss about the 3D. So the other thing is regional wall motion abnormalities. The normal ventricular contraction consists of myocardial thickening. अब जब हम normal LV जिसको बोलते हैं कि LV function normal क्या है, कोई लोग 70 लिख रहे होते हैं, but normally 55 to 60% is the mark that we must think of. Regional contractility wall motion of LV is graded by dividing the LV into segments. हमने 2002 के अंदर एक 17 सेगमेंट मॉडल आया था अमेरिकन सोसाइटी ऑफ एकोकार्डियोग्राफी की तरफ से, और हर उसको लेवल को 3 उसमें हिस्सों में डिवाइड किया गया था, बेसल, मिड और एपिकल। तो बेसल के उन्होंने देयर वर लाइक 6 सेगमेंट्स, जो मिड सेगमेंट्स थे वो 6 थे, एंड एपिकल वर 4 सेगमेंट. तो एंड the last one was the apex itself. तो दिस इज नोन एज द 17 सेगमेंट मॉडल. ये मॉडल आजकल हर कोई फॉलो करता है और इसी के हिसाब से वॉल मोशन एब्नॉर्मलिटीज को डिफाइन करते हैं. वी माइट नॉट गो इनटू द डिटेल्स ऑफ एवरीथिंग, बट बेसिकली हम वॉल मोशन एब्नॉर्मलिटीज की बेसिक्स जरूर डिस्कस करेंगे कि हाइपोकाइनेसिस क्या होती है, एकाइनेसिस क्या होती है, डिस्काइनेसिया क्या होता है. पहले तो आप ये डिफरेंट मॉडल्स आप देख लें कि आप पैरास्टर्नल लॉन्ग एक्सिस व्यू के अंदर आपको एंटीरियर सेप्टम नजर आ रहा है 1, 7 and 14, एंड देन यू सी द infralateral wall 4, 10 and 16 denote basal, mid and apical segments. इसी तरह apical 4 chamber views के अंदर you see the lateral walls 3, 9 और 15 denote कर रही हैं, और ये inferior septum आ गया 6, 12, 13. और इसी तरह 2 chamber के अंदर आप देखेंगे ये राइट साइड के ऊपर 2, 8 and 14 is denoted by the anterior wall, and 5, 11 and 16 denoted by the inferior wall. ये basal, mid और apical segments है. So ये 17 model segment है. And then on the parasternal long axis, short axis, we have got 3 or 4 levels. Basal level के ऊपर आपको 6 के 6 basal segments नजर आएंगे. And when you come to the mid, you can see the anterior segments, and then you see the inferior, and then you see the lateral and infralateral segments over here. Basically, lateral segments नजर आते हैं, infralateral से नजर नहीं आता. And then you go to the apical segment, you see the 4 basic ones: anterior, infralateral, lateral और inferior segments. तो ये चारों, and 17 is the apical cap. तो ये सारे short axis के उसकी differentiation है. ये parasternal long axis का है, apical 4 chamber 2 में. So this is basically a summary of all the wall motions that you need to understand. उसको interpret कैसे करना है. और जो दरमियान में आपको टेबल दिख रहा है, इस टेबल के जरिए आप उसको basal, mid और apical को डिवाइड कर सकते हैं. So this was the one, the segment that was actually introduced by the American Society of Echocardiography in 2002. This model is being followed as till now. So 4 chamber, 2 chamber long axis के अंदर फिर आप देखते हैं चीजों को. तो normal contraction क्या होती है? When there is more than 40% increase in wall thickness with systole, then it is called as normal contraction. When it is 10 to 30% of the thickness 10 to 30% of it is called hypokinesis. When there is 10% or less, it is known as akinetic, where hypokinesis to akinesis. And when with contraction, the segment moves out of the plane, out of the phase, it is known as dyskinesis. So all these things all have to be elaborated with the contraction modes and the areas. उससे आपको regional wall motion abnormalities का पता चल सकता है. So regional wall motion analysis is also very important part. So to determine कि कौन सा area involved है, और आपको segmental wall motion abnormalities मिलती हैं myocarditis के साथ भी मिलती हैं, COVID myocarditis के साथ भी मिलती हैं, Takasabus के साथ भी मिलती हैं, और coronary disease का तो ये basically hallmark है. So these are the two basic things that we normally need to know when we are calculating the wall motion abnormalities and as well as the LV function. A stroke volume is actually not a true indicator of LV systolic function, but it provides the amount of blood that is ejected. Stroke volume can be measured as difference between the LV and diastolic volume and LV and systolic volume. ये भी Simpson method से हम निकाल सकते हैं. तो stroke volume is LVOT area into LVOT VTI. इससे हम कैलकुलेट कर सकते हैं. LVOT area आप कैलकुलेट करते हैं, और फिर VTI कैलकुलेट करके you can calculate the stroke volume, और इससे हम फिर कार्डिक आउटपुट निकाल सकते हैं. कार्डिक आउटपुट का फॉर्मूला क्या है? स्ट्रोक वॉल्यूम इनटू द हार्ट रेट, दैट इज द कार्डिक आउटपुट. अगर आपने उसको कार्डिक इंडेक्स निकालना है तो कार्डिक आउटपुट डिवाइडेड बाय बॉडी सरफेस एरिया, हम कार्डिक इंडेक्स भी निकाल सकते हैं. आई एम सॉरी, मैं थोड़ा सा तेज इसलिए जा रहा हूँ, बहुत सारी चीजें कवर करनी है. सो स्ट्रोक वॉल्यूम का एलवीओटी एरिया, एलवीओटी वीटीआई, उसके साथ आप कैलकुलेट कर सकते हैं, और देन यू कैन कैलकुलेट कार्डिक आउटपुट और कार्डिक इंडेक्स with the help of echocardiogram. All this can be done with echo in the COVID unit as well. So the difference should be equal to stroke volume across the LVOT if there is no valvular, if there is a valvular regurgitation, especially if there is mitral regurgitation, the volume needs to be subtracted to obtain the stroke volume across the LVOT. तो LVOT और को हम एक्चुअली कंपेयर कर रहे होते हैं उसके साथ. अगर माइट्रल वेल्व के अंदर रिवेजिटेशन होगी तो फिर उसमें थोड़ा सा हमें सब्सट्रैक्ट करना पड़ेगा. ये इसकी एक लिमिटेशन है स्ट्रोक वॉल्यूम कैलकुलेशन. Pericardial effusion. Pericardial effusion is very important to diagnose. Along with that, we need to see कि pericardial tamponade तो नहीं हो रहा. That is a very important thing that we need to. तो उसमें आपको जो major सबसे important view होता है, that is the subcostal. Subcostal view के अंदर आप ले सकते हैं. Subcostal view is the best view to understand. And then we can pass on long axis and the apical views as well. So if you see the difference like this one, आपको स्टार नजर आ रहा है. This is all pericardial effusion. आपको descending aorta के साथ आपको इसको देखना होता है. ये differentiate करना होता है. Descending aorta is always behind the effusion. और ये आपका left atrium है और ये आपका left ventricle है. So this amount of fluid is the pericardial effusion. Similarly, this is the LV cavity and this is the RV cavity and this is pericardial effusion. And if you go here, you see like this. This is all pericardial effusion and this is LV cavity and LA. Okay. Pulmonary embolism. Pulmonary embolism, especially when there is deep vein thrombosis, when the Delta variant came into recognition. So we saw a lot of cases of pulmonary embolism, and it was like a catastrophic situation. We कई दफा problems आ रहे थे, तो echo की बहुत जरूरत होती है urgently. तो aortic level at the short axis view is a very important view for this, and also apical view can also be used. So we need to understand कि embolism में होगा क्या. Embolism में RA-RV dilatation होगी. There can be clot in RA or RV. Pulmonary artery में condylar sign positive होगा. Acute pulmonary artery hypertension होगी. So ये सब चीजें देखने के लिए आपको echo का चाहिए. But if you look at this is the right atrium. Huge right atrium, and this is RV. Normally this is not like that. RA is far shorter than the LA and the LV, but in this case, जैसे आप प्रोब रखेंगे आपको नजर आएगा कि RA बहुत ज़्यादा dilated है, RV dilated है. So the first thing that must come into your mind is, and if it is acute, so it can be pulmonary embolism, or भी बहुत सारे signs होते हैं we can discuss. So this is another thing that needs to be taken care of in patients who have pulmonary pericardial effusion. और उसके अलावा फिर pulmonary embolism को देखने के लिए आपको RA-RV dilatation देखना होता है. फिर RV dysfunction भी आप देख सकते हैं. LV function compare with RV dysfunction. RV dysfunction को देखने के लिए हम TAPC यूज करते हैं. Echocardiography is helpful in diagnosis in severe cases, can be used to risk stratify patients to document response to the treatment. So the main problem comes in when there is pulmonary embolism and you have to decide for thrombolytics or not. So it comes with RV dysfunction. RV dysfunction जो है वो बहुत important है. RV dysfunction you have to calculate with it. You see if the RV is dysfunctional, or if there is hemodynamic compromise, then you can use thrombolytics for pulmonary embolism as well. So we need to see RA-RV dilatation, we need to see RV hypokinesis, and mecanal sign also helps with it. Underfilled LV can also be one of the signs, and there can be a D-shaped cavity, D-shaped LV cavity in systole and diastole, or known as systolic septal flattening. Pulmonary artery systolic pressure is usually less than 50, and it may visualize thrombus. So these are the signs that you need to see. If you can see over here, this is septal flattening, ये और ये D-shaped आपकी जो है ना वो LV cavity, और पूरा this is all RV. Putting pressure, systole और diastole दोनों के अंदर आपको ये नजर आएगा. Now you need to see the pressures, you need to calculate the TAPC, and you can also see you can compare RV with the LV. RV और LV जो आपको नजर आ रहा है कि बिल्कुल बराबर है. So when it is such a condition, तो you always think about pericardial tamponade. A cardiac tamponade is an emergency. A cardiac tamponade is a very rare. It can actually happen. it happens with raised JVP, pulsus paradoxus, hypotension, and dyspnea. It can happen with that. Echocardiogram, pleural effusion pericardial effusion, mild, moderate, or severe, can be estimated by echo. Features of pericardial tamponade means RARV collapse, significant respiratory variation in mitral and tricuspid inflow velocities. This is I think sometimes difficult कि अगर आपकी मशीन के अंदर डॉपलर होना चाहिए तो हम कैलकुलेट कर सकते हैं. अगर आपकी मशीन में कैपेबिलिटी नहीं है उसकी to calculate these respiratory variations, तो फिर जरा मुश्किल हो जाता है. बट आपको 2D इमेजेस जो मैंने आपको पहले दिखाए थे उससे भी अंदाजा हो जाएगा कि पेशेंट इज गोइंग थ्रू pericardial tamponade or not. But the better thing is कि if you have got respiratory variation calculation होता है, respiratory meter लगा हुआ है साथ, so it is very important कि आप respiratory variations देखते हैं at the mitral and the tricuspid inflow velocities. So they give you an idea even before the actual tamponade to happen. ये इसको हम pre tamponade भी बोलते हैं कि ये आपको preempt कर देता है उनसे. So there are a lot of things that we can calculate. We can calculate with the M mode, जो pericardial tamponade RV collapse हो रहा होता है, that can be seen. RA collapse later and RV collapse earlier than the RA. So ये आपको calculate करना होता है. So you can see a patient, आप ये देख रहे हैं तो इसके अंदर pericardial tamponade, this is the LV cavity जो कि आपको नजर आ रही है. But when you go to this is the pericardial effusion that we are measuring. And if you see on the RA, इसमें आपको collapse नजर आएगा थोड़ा सा. RA और RV collapse ज्यादा नजर आ रहा है इसके अंदर. So look, the heart is actually dwindling in the cavity, and there's a large effusion that is compressing, and the RA-RV जो है वो इसमें hit हुआ है. Look at this, there's a collapse. RA और RV दोनों collapse कर रहे हैं. So this is one of the signs. And the last thing is the volume status. The main clinical question is hypovolemia. Sometimes people present to us with a mixed picture of fluid overload, and so we need to see the volume status. The best thing is to go and see the subcostal view of the inferior vena cava. Subcostal IVC view लेते हैं, उसके अंदर we can easily see. So we first of all we check कि merge कर रही है our right atrium with IVC, and we measure the IVC diameter from here. And respiratory variation is the cornerstone of patient with volume status. So collapsed IVC and increased respiratory variations are the signs of hypovolemia. So if you see this on the left side, you see there's a collapsed IVC. It shows hypovolemia. उसी patient को जब हमने 2 liter के fluid दिया, IV fluid, you see on the right side कि there's a large difference in the IVC. IVC is not collapsed, it is a normal dilatation. मगर अगर बहुत ज़्यादा dilated हुई भी हो तो that denotes pulmonary hypertension or fluid overload status. So fluid overload can also be seen by IVC. This is a very important mode that we need to learn in the point of care ultrasound. So this is my last slide, and this is very important. If you see the diseases, this is a summary of focus point of care ultrasound, your point of care echocardiogram in the COVID patients, and this guideline has been given to us by the American Society of Echocardiography. If you see on the right side, these are the diseases that are associated, like myocarditis, acute coronary syndrome, cardiomyopathy, or shock. You see there's LV dysfunction that we can see. Then with pulmonary embolism and cardiomyopathy, we can see the right ventricular dysfunction, size and function. So this is basically a summary that we need to see in patients with COVID. ये सब आपको functions आने चाहिए. Tamponade can be seen with pericardium, and there's a large effusion, and then we can also see the valves. Acute glossal agitation or stenosis of the valve can be seen. Then we can see the B lines which can denote the heart failure, and it can denote उसके edema है या pneumonia, इसको differentiate करने के लिए we use the B line. A lines are plural, sides are normal, और B lines अगर आ रही हो तो it means के heart failure की तरफ जा रहे हैं. Pneumonia, ARDS, this is also an 8 or 12 point examination. So that we normally do. With these patients. उसमें B lines देखते हैं, subpleural consolidations देखते हैं, thickened pleura and lobar consolidations and effusion. That goes with. So ये 8 point जो marking है ये सिर्फ उसके लिए होती है. Point of care ultrasound that is used in emergency as well. Then we go and look for JVP or subpostal IBC just to see the fluid status, congestive heart failure and volume के साथ होती है. And then the DVT comes with 2-point compression plus minus of the leg veins. So all these, this is the summary of the things that we have to see in the patient with COVID. So I think this is very brief as I could be in 20 minutes, but I think it needs more elaboration and hands-on training for all the people who are working in COVID. So I think this is a very important topic, and I think we can actually work on that more. If there are any questions, I'm happy to answer. Thank you very much.
Yeah. Thank you, Imran, for interesting talk regarding the role of echocardiography in COVID patients. My question is, you didn't mention anything about the strain pattern. And I think what's the role of assessing LV strain before developing systolic dysfunction in patients who are COVID infected, not COVID positive, but patients who are COVID infected and are sick in the ICU?
Okay. First of all, even performing the echo is very difficult in these patients because, can you hear me, please?
Yes, I can.
Okay. So performing echo and all the logistics have shown us, even at the very good centers, we were using the worst machines and the neglected machines, we used to drag it. So the strain pattern actually is not available in most of the machines. That yes, strain pattern can preempt you for these sort of LV dysfunctions in patients, but normally the LV dysfunction that we see in COVID patients is quite rapid. Within days we see the changes, and for a patient like we use in chemotherapies, when we use chemotherapy agents, we can predict that this LV will go down, although the LV is fine. But yes, it can be used, but the duration of action is so rapid in COVID that we don't have time to even preempt. And the other thing was the logistic issues. We were having a lot of problems, and strain was not available. Actually, to my knowledge, even the best centers in Karachi didn't have it.
What was the incidence of this COVID-related myocardial dysfunction, or you say COVID-related myocarditis or cardiomyopathy?
As compared to the positive troponins, it is very low, but we do see myocarditis like in the last 2 or 3 years in my practice. I would have seen like 7 or 8 patients, not more than that, in the private practice. Even in Indus, we have seen like 10 or 12 patients, not more than that. I don't think the incidence is that much high, but the troponin is high for any other patient who's coming with the COVID. Actually, I made this talk just for the beginners and the residents and the echo text. So it was very and a lot of details were there.
But recently there was a lot of talk about this vaccine-related myocardial dysfunction. Remember, I think it was published in New England also.
Yeah. So I've seen 2 or 3 patients with this presentation. One in my private practice, it was a 16-year-old girl who just got her Pfizer vaccine, and she developed myocarditis. But then she also developed pulmonary hypertension, and the right ventricular pressures were down. But with the help of steroids and everything, she came back. And the other girl that we saw in Indus Hospital, she also got this myocarditis, but Her LV was really gone down to like 10 or 15%. But later it also improved. Like 2 or 3 cases were reported, and yes, it is a possibility, especially in young individuals, 16 to 18 to 20 years. I've
My
seen few
question
of them.
to my question to Rizwan, is there a dedicated echo service or echo machine in your COVID ward?
आवाज नहीं
Yeah, we can hear you. The question is, you have a separate echo
No.
machine and an echo service for your COVID ward or the COVID ICU, the COVID patients.
So during the peak of the pandemic, there was a tech who was on call for just the COVID patients for the hospital. So they would just go around the hospital and would see the same person wearing the same, using the same machine for the rest of the hospital, and then there was some dedicated machines for the non-COVID patients. I'll tell you, I did volunteer um, um, to take care of COVID patients in New York, close to the Ailments hospital, and I had various conversations with residents and attendings that were taking care of the patients in March and April of 2020, and numerous times there were patients who were waiting 3 days, 4 days for an echocardiogram in New York City. I'm in Albany, so we didn't have that many patients. So you can imagine, even in a big city like that, they were waiting 2 days for a critically ill patient to get an echo. So in my hospital, we had one person who was going around. There was enough, task for that person all day. That person was dedicated for COVID patients only. So probably we have more machines than other hospitals, but that's how we took care of it.
I feel that at our center, as well as all other centers, must develop their own guidelines for the specific points in echocardiography. We had a very short handheld machine that we used for doing echoes throughout the hospital, and it was very handy for us. I think if we just focus on these 5 or 6 points, it will help us.
We did. I should add here though that the cardiologists who were assigned, and we had a team of cardiologists that just took care of COVID patients as well, uh, and they did have handheld ultrasounds from Philips that we used. So we had three for our practice. So we would use one for CCU, one for the medical ICU, and they would have it in their coat pockets, and they would use it right there and there.
And we
Well,
even use the butterfly probes for that.
Yep.
well, thank you for this interesting session. I think I just want final comment from anyone who's interested. What's the speculation for this COVID in this coming year? United Kingdom has taken a very different 180-degree approach yesterday, and they have lifted the restrictions, asked people to stop wearing masks. So, how do you see? Is my question to Rizwan. Do you think this epidemic or the pandemic is going to end by the end of the year? Things are going to return to normal, or the life is going to continue like this?
I, I'm gonna. So I'm not Fauci, first of all, and I don't know where the next variant's going to come. I've only heard throughout the media that we will fight this virus. Nobody has said we will pray that this virus goes away, and I hope and pray that this virus goes away. So we need to stop fighting the virus. Um, I, it looks like, and again, I don't have any data, but anecdotally this Omicron's going through the population very fast. And I think maybe we can only hope that this is a nature's vaccine for the rest of the population. So I don't know how much this is going to how long it's going to take, but it looks like we are getting a lesser aggressive variant every step down. So let's hope that it goes away, and let's pray that it goes away.
Yeah.
Yes, I think we all think the same.
A question for Dr. Rizwan. Can you hear?
I can hear you, Ahmed.
So this issue about COVID pneumonia and atrial fibrillation with fast ventricular rate, one of the medicines that we liberally use in other patients is amiodarone, but this COVID-19 is in itself a fibrosing lung disease. It leads to a lot of lung fibrosis, and amiodarone also has the same side effects. So it's not one of the drug of choice in atrial fibrillation. So what are the other options that one can use?
Certainly, I think even if you take out the COVID out of the factor, the patients with sepsis and ICU patients, amiodarone has some indicators that it adds into the mortality, or at least length of stay. As long the amiodarone is in the system, the length of stay, it's been correlated with that. I'll tell you that with the worldwide survey that the data I presented, amiodarone was in fact the most common drug used because of the scarcity of resources and medicines. So not everybody has ticacin, dofetilide, sotalol, etc. In United States, we did use a lot of esmolol. It has been associated with lesser adverse events or outcomes than amiodarone or digoxin. So esmolol was used quite frequently in those patients, and that's how we dealt with it. Amiodarone was still used, but with precaution, because making sure that there's no transaminitis, there is no chemical indications for us to not use it. At that time, it was just in the beginning, I think we were learning that we were just patching things to keep people alive.
Great. I think I would like to thank all of you, Dr. Rizwan, Almohammad from New York, Ahmed, Noor, consultant cardiologist, Indus, Imran, Iftikhar. Thank you all, Dr. Asadullah Kundi, who has been with us. Thank you all for your participation, and we hope to see you, inshallah, next year for this conference. Thank you very much.